That's good.
All right, John, we're live again from the American Academy of Fixed Prosthodontics meeting. I'm Wes, the dental guy.
I'm John, the dental guy.
John, another high-level
Yeah.
conversation is getting ready to go down.
Been looking forward to this one.
And we just had a little prelude to this,
Yeah.
and I'm already got my blood pressure up a little bit. Right, check your watches, guys.
That's right.
This
Check
one is
the heart
coming
rate.
your way right now.
So we have Dr. Ronnie Young with us here today, and you know, for most of you who have listened to the show are familiar with who this is. Talk a little bit about where you are, what you do, so that for listeners that might not know as much about you, tell us about yourself a bit first.
Hi guys, I'm very happy to be here.
Yeah, thank you.
I'm from the University of Zurich in Switzerland. I'm the professor for implantology at the Department of Fixed and Removable Prosthodontics, and I'm trained as an oral surgeon, as a prosthodontist, so that gives me kind of both views.
Yes.
And I think that's also very important in order to really provide the entire workflow from the initial diagnostics until you really deliver the reconstruction. So you need to see then all the details in there.
Yes.
Now you're speaking on a particular topic here. Speak a little bit just about the title of your topic, and we're going to talk about some other things regarding.
Right, because when we saw the title, it said, you know, what we have learned from wrong decisions and complications. And you know, as we were talking before we started the show, there's a lot of obviously things that have changed and failures that we've seen. And you know, you had mentioned that a lot of what you'd be speaking about is from a restorative standpoint. And let's dive right into that, talking about abutment, material selection, how some of the things we've seen with tissue thickness have changed the way we think about abutment selection.
So the overall aim is really kind of to provide the dentist with a kind of a nice, clear decision tree in order to provide them really with a clear structure. That's everybody what loves to have then in daily practice. We have to deal with so many issues. And the aim is really kind of to provide from a clinical but also from a scientific point of view a kind of a clear structure. And there are multiple parameters which influence actually our decision process. Starting initially with obviously with safety reasons and long-term perspective, which are the materials which have really a long-term perspective. Then its influences by biology, how these materials interact and with the biology there. It's dependent on the costs obviously as well. So that is also an important driver for decision. And then also aesthetic reasons which are going to influence on what type of abutment reconstruction we're going to use.
Okay, and so you mentioned again before the show, we were talking about how what we used to have in terms of when we had a thin tissue situation. Tell us a little bit about what you are using more today. Specifically, let's speak to which type of abutment, whether it be you know, gold colored, pink colored, white colored. We have all these options now. You know, what are some of the parameters that guide those decisions for you?
That's kind of the question, what would you use for your daughter? I think this is the typical question for that.
Yes.
Years ago, I would say 12 years ago, I was really kind of upset about the fact that people have pushed the old ceramic issues without having any measurable benefits. I always want to talk about measurable benefits. And this was then a driving force for us in order to try to objectively assess what are the parameters which are going to make a soft tissue look more grayish or kind of more natural. And there we started to really assess systematically the different materials in terms of their effect on the soft tissue color and depending also on the soft tissue thickness. And there are some studies which have been really heavily cited, which we came to the conclusion that when we have a tissue which has a thickness of 2 millimeters or more, then it doesn't matter that much what kind of material is underneath. When it's 2 millimeters or less, you should either go for an all ceramic abutment, an all ceramic reconstruction in order to avoid kind of the shine through part, or you kind of change then the biotype by increasing the thickness of the tissue, soft tissue by performing a connective tissue graft. So these are kind of the two options.
And what about some of these other colors, such as gold or pink colored abutments? Where do those fall if you say have a situation where the size or the thickness of the abutment is a concern for an all ceramic abutment?
So at the end, when we looked at the different colors, also kind of the pink color, which we once were thinking we had an RCT where we compared a pink abutment versus just Ciccone, a white abutment. And we were sure that the pink will perform better than the white one, but it was not the case. because it does seem that the white part on the knees gets enough lightness into the tissue, which makes it look more natural compared to a color which is the same, basically the same color as the soft tissue, but it seems to kind of block the light there. So at the end of the day, still the best color when it comes to trying to avoid any discoloration is kind of a whitish tooth color on the knees, and not gold, and not kind of silver titanium, and not pink.
Interesting, because you have companies that have even developed implants with a pink top.
Yes.
As a thought of trying to but again, pink is just not as effective as white.
The good thing about the ones which have a pink column there is the fact that when you really have a recession, then it's obviously less visible than with a white dish, because the white dish abutment is then also kind of obviously visible, and it looks kind of strange, and that's the good part about the pink part. So from that point of view, whenever it's kind of underneath the soft tissue, it seems to be whitish or tooth color like is the best, the tooth itself. But obviously when it comes to recession, then it's better to be in pink than it be metal or white.
I think one of the things as a restoring clinician and being a surgeon, understanding that implant position, how it affects this choice is massive. Like it's like this idea that the position of that implant is going to so affect your abutment choice and design, and then and understanding that before the tooth's ever removed or before the implant's ever placed, how much these things affect our choices, because you made it's a pretty hard line choice now. You get your perio probe out at the day that you're taking your implant level impression, and you measure the horizontal thickness of soft tissue. If it measures more than 2, hey, we've got some options. If it measures less than 2, we're going to use a porcelain, ceramic, or some type of...
Or if you don't have enough structural, if you're concerned about strength of an all-ceramic abutment, you are forced then to augment the tissue if you want that pink aesthetic score to be where you would want it to be. And that is that correct? I mean...
Yes, obviously, but the problem is then also that it becomes the much more technique sensitive, and not everybody is kind of a periodontist and used to deal with connective tissue graft, which is a kind of a technique sensitive treatment. And as you said, I think the key is definitely the implant position. That's for sure. It's also the question about, we do a lot of research also comparing titanium implants with Ciccone implants, and still up to date, people are kind of think that using a Ciccone implant is more aesthetic because you don't have a shine through, and that's totally not rational, because when an implant shines through, this implant is massively misplaced, and or your augmentation failed completely, and this has basically nothing to do with the implant color. It's just it's a surgical issue and a position issue. So an implant which is perfectly placed, which has healthy tissue around it, will never shine through. So when you have, coming back to the daughter's question, my preferred choice for doing an implant in my daughter's anterior implants, interior teeth side, would be a titanium bone level type of implant, and then a one-piece zirconia abutment, which is directly veneered.
Yeah, one piece compared to bonded to a tie base.
Yes.
Interesting. So even though you're not concerned about the material there, as far as either titanium, zirconia wear at the interface, or problems with strength.
So I think we have a pretty good documentation with this one-piece Ciccone implants, also compared to titanium abutments over a period of more than 5 years. So there have been a couple of systematic reviews which we have been part of, and in spite of the fact that we have much more data for titanium abutment than for Ciccone abutment, within that limitation, the data are the same. So we don't see a significant difference between one and the other. However, one issue is kind of the wear we have with the zirconia, which I actually really don't know what effect this is. What we can say is, when it comes to the clinical performance and all the measures which you can measure from a peri-implant health perspective, you don't see a difference there. Maybe we are too early and we don't see the consequences which might happen after 10 years or 15 years, whatever. But I do have to say, within now, being now not anymore a university professor, being now a practitioner, I have to say this is my clear choice, and this is how I would restore my daughter.
So you feel like that some of the research that's coming out, you know, there's whether we're talking a deep conical connection or whether we're talking a internal, you know, flat to flat with a, you know, a small, you know, conical connection at the coronal portion at a bone level implant, this micro movement that you'll have in all implants, right? With a zirconia to a titanium connection, there's been a lot of talking about, like, what is that looking like long term? Like,
Right.
because we
titanium
know,
particles.
because titanium
is that
particles
an issue?
is that an issue, and we know zirconia is such a hard material.
But clinically, you're not
seeing the
seeing
problems.
problems.
Obviously, you see when you take out, or when you have to take out then the Ciccone abutments out of the interface with the titanium implant, you do see then the kind of the black lines there.
Yeah.
That's clinical reality. That's clinical reality.
Yeah.
But so far we have not been able to detect anything from a clinical point of view.
So let me ask you this: what type of screw are you using to hold the restoration in the abutment? Are you using a zirconia screw, or are you using a gold screw, or are you using a titanium screw?
A titanium screw.
So
for the implant, now we're talking titanium implants. They got to get the titanium screw. It's another topic when we're dealing then with two-piece zirconia implants. I think this is just a completely different open field.
Yes.
Where luckily I still think it's nice to have a lot of open questions. Otherwise, it gets boring. And I think we have such a great profession, having still so many things to look at and to discuss about.
So let's change the subject, because that's a great discussion. Let's talk about how, you know, we're talking about failures, complications, how it's changed our thinking. It's a big topic to open the top on Pandora's box, but let's talk about cementing versus screw retention, because it's been obviously a hugely controversial topic over the last 20 years or more.
John cannot wait to listen to that.
I'm so excited to hear your thinking, because you did tell me you were quite passionate about this. So kind of expand the Ronnie Young philosophy of cemented versus screw retained, and if that's changed or how that's changed over the years.
I think it hasn't really dramatically changed, I have to say. So to make a long story short, to show what I'm passionate and emotional about is that I'm a total believer that screw retain is the only really reasonable solution. And we do get more and more evidence.
I was nervous.
Yeah, I know. I was a little nervous about what you were going to say.
I thought.
Now I can be relieved.
Okay, I'm relaxing.
You can both relax.
Yes.
Look at the watch.
Yeah, check my
blood pressure.
blood pressure is a little high, but it's going down.
Yeah,
it's going down now.
No, I think we do have also the evidence, and I know that the US was a big market, or still is a big market for cemented reconstructions, and especially I loved the study from John Ager, the very famous one, which I teach to every student. I think it's just a simple question, but it was so kind of obvious to see that we are simply not able to remove cement on a level of 1.5
no matter
to
what
3
margin
millimeter.
position we have.
Right.
And on top, then it comes now not talking as an oral surgeon, as a prosthodontist. I would love to listen from a person which is crazy about cementing the reconstruction. Where are really the benefits? Because everything is more difficult. It is more difficult, number one, to remove the cement. It is obviously more difficult to dry the crowns in, because when you place it in, you have the soft tissue pressure, which pushes the crown out. So it basically can never check the occlusion. Then you can never really check a proper emergence profile. You cannot check the contact point, mesial and distal to the tooth. When I screw it in, I make a dry in, I can test everything in a most calm way. I don't even need a dental assistant to do anything in order to check this. Obviously, I have a hole there. And when you really have a kind of a backwards planning where you implant, coming back to the implant positioning, when the implant is placed properly, there is literally no reason why to not screw it in a reconstruction. And we do have now also evidence on systematic reviews, which have shown that we have about the same amount of complications with screw retained and cement reconstruction, but the type of complications are different. So for the screw retained reconstruction, you have more kind of technical complications. whereas then the cement reconstructions have more biological complications. And at the end of the day, it's obvious, and nobody wants to have biological complications. Both are annoying. Also, a screw loosening is annoying, but it's a simple thing, and it doesn't harm anything and no tissues.
So in those situations where you have non-ideal implant placement, because as you said, if you have ideal implant placement, there is no reason not to screw retain. In the non-ideal implant position situations, tell us about some of the approaches that you're using. Obviously, there's a lot of new techniques. You know, we have some old techniques, lingual set screws, for instance, but we have some newer techniques, altered screw channel access, new ways of fixating these. Are you using a lot of that, or are you relying more on just we need the implant to be in the right position? I mean, when are you cementing? I guess that's the question I would ask you.
So I only, obviously when the implants are placed within the University of Zurich in our department, then the planning is expected to be as properly as possible, that we actually never are in a situation where we cannot screw retain. As I say, today we have with the new screws, with the new screwdrivers, which you already can compensate a little bit of a displacement or an angulation there. I think that's really very, we have much more varieties today available. But you do have also to deal with patients which have got implants abroad, which have then changed the dentist because they are not happy about that. They could feel it something, and these implants are kind of going in all directions. And there is then no other way than to go for a cement reconstruction. There we just try to make it reconstruction like this, also following the John Ager's kind of philosophy to be really very close to the margin, and then to be, I would not go further than 1 to 1.5 millimeters subgingially. And what you could do is then kind of to individualize then the abutment in this area, in order to have, when you have a little bit of a recession, that it's not exposing the whitish part, then it's kind of then really more something which is tooth colored.
Does a patient's disease status affect your decision in any way? For instance, you know, periodontal disease, a history of it. Once a periodontal disease patient, always a periodontal disease patient. That's our mantra in my office and John's office. And even more now, I was telling John the other day, if I had a patient that was a controlled periodontal disease status, but they needed a dental implant, and it was a situation where maybe, you know, something happened and this restoration could not be screw retained, whether it was a mechanical limitation of the system or whether it was just an improper placement or couldn't be achieved. Even then, I looked to John and I said, you know, I think I'm willing to accept some cosmetic appearance of a screw access hole on the facial surface or the labial surface because there's so much evidence. Do you feel like there's enough evidence to say no cement in any history of periodontal disease?
I think we actually could go in this direction. And I think it might not be that much of an issue having then the screw access hole more to the buccal aspect. On the other hand, you can also say when you're really in a periodontal situation with a patient, you can easily place your crown marching above the the soft tissue level
and use a zirconia abutment.
Yes. So because the aesthetic issues are anyway in a kind of in a
compromised state,
second line, so to say. So from that point of view, there you could theoretically, but on top, then also the flexibility you have encountered with screw retention is also a striking motivation to go for screw retained reconstruction, especially a periodontal patient. Again, now when she or he has then further tooth loss, then it's so much easier to retrieve than the reconstruction, add an additional implant, go for a bridge and whatever, without the need to damage then this crown and to get access then to this cemented reconstruction.
It's a great point. I think one of the things that whenever you lead into the topic of screw retain, it's what type of an abutment to prosthetic connection do you have, right?
Yeah, and we've seen a move away, or well, not away, but toward tie bases as a way to make these screw retain restorations. Speak a little bit to that. We talked a bit before the show as far as some concerns you had about the tie base kind of phenomenon, as maybe we'd call it, that's happened. Tell us a little bit about, you know, what are you worried about with that? What do you see happening with those? Where are we with tie bases?
We definitely can say that with with a tie-base abutment, they have been entered the market as fast as no other abutment before. And this is primarily driven through the financial issues, because it has been at the time where the gold prices are so high, it was something which people were waiting for in order to provide with more kind of less expensive solutions. And for instance, Switzerland, there are close to 60% of all the abutments which are sold are tie-base abutment.
Wow.
So they're really kind of the dominant part. And we have to emphasize the fact that we are lacking, really kind of completely lacking long-term data on titanium-based abutment. Through the fact that they have been entered the market so fast, a lot of centers, the other university have started, initiated, and have ongoing studies in that direction, including us. So we run 5 studies in this direction. The in vitro studies, they are fast to be done. They have shown, number one, that from a stability point of view, they are as good as titanium abutments. And they are definitely above all the Ciccone abutments. Number two, when we have a kind of an aging of 5 years in chewing machines, we do see in about a third of these abutments, that's now the most current data, just publication which has been accepted 2 weeks ago, that in 1/3 of the cases we do have a gap formation in between the titanium base and the cemented
In
abutment.
1/3?
In 1/3 of the cases.
Wow.
And in another study which is still ongoing, where we have as kind of a special shape of the titanium base, which is relatively wide there, we have seen also in about 1/3 of the cases really bone loss, which we haven't seen in any other cases.
So versus coming out like a chimney and then coming up with your restoration.
No, they're relatively close.
Right,
they get wider relatively close to the...
It flares very quickly off the platform.
Exactly.
Okay.
Exactly.
And in a third of those, you're seeing kind of unexplained bone loss compared to
Patient
identical type of abutment that's a full contour.
Which patients are totally healthy, kind of no typical risky patients. And so this made us kind of really thinking and kind of became a little bit more cautious about trying to understand better what's going to happen on a biological level, because we do have an interface very close to the most crucial areas, right at the level of the bone and the soft tissue. And therefore, I think it's still abutment which is heavily used also in our clinic, but we have to face the fact that we are really lacking the data, and we don't know whether this will have an impact.
Let me speak to a prosthetic complication that I just had this week. I had a patient that was referred to me back in 2011 that needed a dental implant restored in site number 30. And at the time, this particular implant, you probably would know it well. I'll not mention it. It's an excellent implant. And, you know, our lab was building our full contour crown on a tie base. So it was a zirconia crown, screw retain restoration to a tie base. This patient comes in, they'd been to their dentist, and the dentist on recare noticed that the crown was loose, and he comes back and he's like, hey, my crown feels like it's a little loose. Immediately I thought, simple problem, we probably just screw come loose. And so I prepped through the occlusal surface where I had the composite, took the Teflon out, screw was tight. I knew immediately what had happened. I had a debond. And then I had to, proceeded to get that off. And that's what we're talking about here. And this was restored in 2013. And this is a patient that has a full complement of occlusion.
But my concern, I mean, the debond is a technical complication that is a concern, right? But we can, I think, compensate somewhat for that with, better designs and things. But this biologic complication risk that I mean,
you're talking about basically.
Are we dealing with a cement problem? The same as what we could be dealing with the cement retain restoration, except that it takes a while to develop? I mean, is that what the theory might be, or?
I think it's a different thing, because with the cement excess issue, it's more like we are not capable of properly or removing 100% of the cement here. That's not the case, because this can be done in the lab.
Yeah.
But still, there is a gap in between, which is more prone to have bacteria in there, and also maybe also chemical issues taking place at that level. So from an ideal point of view, you anyway want to have something which is actually which has in this area no interface.
Yes. And we don't know how far we need that interface to be away from
I was
the
going
bone.
to say, what do you think the average distance from platform of implant to crown margin
interface,
crown interface is that you're seeing that's available for, that most people are using? Like,
I think a lot of people are using just the smallest one, which is just about 1 millimeter above.
So basically, we're
because
putting
with this, you're kind of out of the discussion how far you can go up. Because the higher you get, it gets a little bit more critical regarding then the soft tissue height and so on. When you take just the 1 millimeter, then you're kind of safe from an aesthetic point of view because everything happens underneath. But the compromise is then that you're kind of really in this area where it's most critical about. And this is something which we really should take serious and should be kind of on our toes to look for the future, what's going to happen there.
So what do you think your ideal abutment is? Tooth number 19, 30, 3, and 14 are the most replaced teeth in the world. From a standpoint of implants go, what should we be really looking? Should we go back to full contour milled abutments out of titanium or zirconia in the posterior primarily, and then cementing, outside of the mouth, obviously, and basically a cemented retained, screw mentable situation?
So we just talked before, John and I, a little bit about this topic. I think this will be a major change in the future, because when we look critically at the situation today, we are trying to connect two different worlds, which one is a very advanced world, which is the kind of the prosthetic world with all the CAD/CAM technology, 3D printing, and so on. On the other hand, we have a very mechanical world on the level of the implant interface connection. The implant companies are primarily focusing on different shapes, different screws, different tabs, and so on, in order to make it more fancy there. But the connection is about since 30 years the same. And I think we should look for connections, and there are development ongoing, which allow actually a direct CAD/CAM abutment without any need to buy any titanium base or whatever abutment, any zirconia which needs to go into the conical part, that you have an interface there which you can 3D print, which you can manufacture in any way, which directly goes on the implant. So that there is a need to kind of improve the implant prosthetic interface.
And so you would be going back to, again, in a way, the same thing you'd choose for your daughter in the anterior. You'd be going to potentially a one-piece type of, because does that mean that you're going back to that original discussion, when you say you would choose a one-piece zirconia abutment, is the reason why you would go potentially away from a titanium interface with that in the anterior for the same reason, because you're concerned about having that additional interface down below tissue?
So far I take the one-piece zirconia implant for my daughter because I do believe we have no interface. I have the best biological material as the interface and soft tissue, and I have maximum flexibility in terms of the emergence profile. Because we also know today that compared to how we did the crowns 15, 20 years ago, where we kind of started like this, getting a crown, we try to be as narrow as possible to give the soft tissue as much thickness as possible. And then you come relatively late. You become then wider in order to get to the final emergence profile. And I just take this one-piece zirconia abutment today as the best solution, knowing that we have some mechanical issues going on in between the interface of the zirconia part, which is in the conical aspect of the titanium implant.
So you say there's development ongoing on this idea of trying to develop this exact type of abutment, and is that a result of some of this data that's concerning us about tie bases?
That was the driver actually then.
Okay.
That was the driver.
And I guess too, you have to do, well, you don't have to, but it would be nice if it was a cost-effective solution as well, because in order to be competitive in the marketplace,
you are, because then you don't even need to buy any kind of piece in between. You can directly fabricate this as a CAD/CAM solution directly on the implant. So you also save, you have less interfaces and you save a component.
Yes, and if that could be, I mean, that would truly be the next level if we could have that, and we could have a one-piece solution for every case, and even then integrating in some of these new technologies such as like altered screw channel access or thing, and you could have that all milled in one piece or printed in one piece and cast or whatever you would choose.
Exactly.
Well, this is good stuff. It's challenging. It's challenging because I think I wasn't surprised to hear you speak of screw retention the way you did but I think in the U.S., like you say, we're still digging our way out of that problem, unfortunately, with cement retention. And I think it comes down to, I mean, what you asked before, what are the advantages? I think the only advantage is that it is like what you're used to doing with teeth.
Right. It simplifies things from a standpoint of a new budding clinician.
Yeah.
They know how to adjust proximal contacts and try on a crown.
But I think that when you look at this, and it's still amazing if you're all this controversy, all this discussion, that's still, as we talk to laboratories, we will talk to laboratories, and they will still say, I don't believe cement is a problem. And if the laboratory is saying that to the clinician that maybe doesn't have this information, then the clinicians, obviously they need to learn, but the laboratories, I think, are the ones that really are going to have to, because the price and the ease, quote unquote, of that is driving a lot of the market.
Yes, absolutely.
Very good. Very good.
We really appreciate you spending time with us today
and
giving us some good things to think about. And if you've enjoyed, what we've talked about today, first of all, where can they learn more about what you're doing? Is there tell us about that? Like, you have anything that you want to kind of share with us as far as what's happening in your world that information or training, or what are you kind of most proud of right now?
What we have done, actually, we have started also today with Quintessence 12 years ago, kind of an online platform which is called Dental Campus, and which actually for us so far the only worldwide platform which has completely structured content, everything peer-reviewed and generic, so with no influence from companies. And this is going to be, I think this is going to be the future of how we will learn there as well. And there are kind of the things which we discussed today are in that platform, and you can check this out at www.dental-campus.com.
Awesome.
Okay, well, that's great. So learn more about this and, get your blood pressure up a little bit. And maybe that'll challenge you to change some things. And again, if you're learning about us here today during this interview, come follow us on YouTube and on the social media channels, Facebook and Instagram. And tell us what you thought about this. Tell us what challenged you, and tell us what you want to hear more about. So for Wes and myself and Dr. Young, we are the Dental Guys. Okay.